All right, welcome to Friday Chalk Talk. Today we have Dr. Kathleen Sawaski. She is a chocolate-loving internist with 24 years of experience in primary care and internal medicine at Frederick Medical College of Wisconsin. She is doing a fellowship in geriatric medicine since September of 2021 and will be finishing up in a few months. And she is doing a rotation here with us at St. Luke's in palliative care. So she is going to be talking to us today about the 5 W's of delirium. So I will pass that over to Kathleen now. Thank you.
Thank you. So we'll talk about delirium today. This is a topic that's huge, obviously, in geriatrics. I'm sure you guys see it as well. I'll try not to bore you. Hopefully we can just get through this and we'll talk about delirium. So what is it? Who gets it? Why do people get it? Why does it matter? And what can you do about it?
Our case for discussion today is of an 87-year-old female who has a history of severe vascular dementia. She's seen at a home hospice visit for agitation, changes in mental status and behaviors. She lives with a large family who all have this wonderful rotation of being there 24/7. And she was recently admitted to a local hospital 4 weeks ago after a fall, and that fall is what led to her recent hospice admission.
Since she's been home for the last 3 weeks, really barely speaking, barely eating, very agitated and restless, scratching herself, causing sores, frequently readjusting her clothing, her blankets. All right, so she had a video visit completed with her primary care physician. She was in the resident clinic. She was given lorazepam at bedtime, which helped her minimally. So they increased the dose and that didn't really help either. So then they started quetiapine, 12.5 milligrams at bedtime, which didn't really help her. So then they asked us if we would mind doing a home visit. On our exam, kind of waxing and waning level of alertness. She was lethargic. She would awaken to verbal stimuli occasionally and speak a few sentences. She'd try to answer some questions, but didn't really remember much about current events if you asked her, particularly even her history, that she didn't remember she was in the hospital. Doesn't follow commands. When she was out, Cheyne-Stokes respirations were noted. Pulse ox ranging from 81 to 90% on room air. Blood pressure was 120/60 with a pulse of 60. Her lungs showed some atelectasis at the left base. She had some rales that cleared when she coughed. Heart was regular, no murmur. She had no edema. Her weight was back to her baseline. So the 15 pounds up from baseline she was when she was discharged from the hospital, it was gone. So she had no edema, dependent rubor to the left lower extremity, a bandage on each shin, healing wound to the dorsal left distal metatarsal region. Her feet were warm. Labs pretty unremarkable. This stable mild anemia, sodium was 144, calcium of 9, albumin not too bad at 3.3. Renal function was stable, glucose 128, ammonia normal, LFTs were normal. Her daughter did have some videos of these behaviors that she found very concerning that she shared with us. The video during the day, mom was sitting in her chair, she was wearing her nightgown, but she was watching a movie on TV. And just frequently would get up, like every 10 seconds or so. She'd stand up and then she'd start fidgeting with her nightgown. She's readjusting it, she's pulling it down, she's pulling it off her shoulder, can't get comfortable, then she'd sit down. 5 seconds later, she's standing up again and she's using her walker to get up, and then she's readjusting and pulling it down and just fidgeting and very restless. At night, she had videos of mom, and this is the classic, kicking her legs over the bed, throwing the covers off, trying to get out of bed, fidgeting with her nightgown, trying to get up, then sitting back down and doing the same thing, and on and on and on. And this would go on for hours and hours and hours. So we felt she had delirium. We increased her quetiapine to 12.5 to 25 in the morning, and at noon, 25 to 37.5 at bedtime. No significant change. So then she was admitted to another hospital for hyperactive delirium that was uncontrolled on her meds at home. They started her on some Haldol. She was then transferred to a residential hospice facility a couple of days later. I actually had the privilege of taking care of her there on my rotations, and she passed away comfortably, very comfortably a few days later. So we're going to talk about delirium. We felt she had delirium. This is an acute disorder of fluctuating cognition and attention, also characterized with disorganized thinking and or an altered level of consciousness. This is the DSM-5 criteria for a delirium diagnosis. And again, we see a disturbance in attention. They either can't direct their attention, they can't sustain their attention, can't shift their attention. Also a disturbance in awareness, so reduced orientation to their environment. This disturbance is acute, usually occurring over hours to a few days, and it's a change from their baseline. And it may fluctuate in severity throughout the course of the day. And then we also see an additional disturbance in their cognition. So maybe a memory deficit or disorientation. There may be hallucinations, problems with language. These disturbances are usually not better explained by another pre-existing problem, like an underlying neurocognitive disorder or depression. And then there's evidence from the history or physical exam or lab findings of something you can attribute it to, something that's causing the delirium. So delirium may be hyperactive like our patient had, and this is the one we commonly recognize. These are the people that are yelling and screaming, and they're restless, and they're picking at things, and they're throwing off the covers, and they're trying to get out of bed. They tend to be quite impulsive. Hypoactive is actually more common, but less commonly recognized, because often we just think these people are sleepy, but they're lethargic. So the hypoactive delirium is the more common form, actually. There's also a mixed form. Delirium is often difficult to distinguish from underlying dementia or depression or psychosis. But if you see an acute change in their mental status from the baseline or inattention, that's going to point you more towards a diagnosis of delirium, or a change in the level of consciousness is also going to make you think more delirium. So here's just a table I pulled from a JAMA article about delirium. So again, an acute change in mental status is going to be found in delirium, but not really if they've got dementia or depression. And likewise, altered consciousness will favor delirium. Here's where history is actually very, very helpful for you. So getting collateral history or collateral information from the care team. So if it's someone who's in the hospital, talking to the nursing staff who know the patient well, or the others on the care team, talking to the family if it's something that's happening at home. When did this happen? You know, what are the details surrounding it? What's the baseline? So really knowing the baseline cognition is going to help you. If this patient has underlying dementia, what do they normally know? Are they normally oriented to the day and the date, or at least to, you know, their name and their birth date and things like that can help you. So who gets delirium? Anyone can develop delirium. Up to 80% of patients of any age in the ICU who are mechanically ventilated will typically develop delirium. Predisposing factors, so who more commonly is going to develop delirium, is going to be the frail elderly, those who have underlying cognitive impairment, those with multiple comorbidities, including depression, polypharmacy, those with impaired sensation, so decreased hearing or vision, impaired functional ability, so people who have trouble with their ADLs, people with a history of alcohol misuse or malnutrition, and a history of anemia. And why do people get delirium? And again, the causes are myriad. This is not an all-inclusive list, but very common as to what we all see. Those who are hospitalized with severe illness, sepsis, stroke, MI, an infection, presence of tethers like lines, Foley catheters, restraints, surgery, anesthesia, medications. And this is starting a new medication. It could be stopping a medication can cause delirium. Benzodiazepines are a horrible cause of delirium, frequent cause of delirium. Anti-nausea meds, the tricyclics, steroids, opioids. This is a short list, but basically any drug, and again, starting or stopping it. The bladder antispasmodics, any other drugs that are highly anticholinergic, frequently can cause delirium. Uncontrolled pain and environment change, like going to the ICU. Dehydration, electrolyte disturbances, urinary retention or fecal impaction. So those are common things. Frequently when we get a consult for a change in mental status on an elderly patient, we'll ask them to check a bladder scan and get a KUB, you know, kind of just off the bat. Hypoxia, hepatic and renal failure, and also if someone's dying, we see delirium. So why does delirium matter? We did a systematic review in older adults, reviewing the literature and delirium in those over the age of 55 who had a diagnosis of delirium while hospitalized. And we found an increase in mortality. And there was one study we looked at, it had 229 patients enrolled. all over the age of 70 and showed an up to 50% mortality at 1 year post-hospitalization. The average age of those patients was 78. There was another study we found that showed a decrease in cognition. Now, there were actually multiple studies, but one study of 309 patients, again, at mean age of 78. These patients did not have any pre-existing cognitive decline prior to their hospitalization, but if they developed delirium while hospitalized, it was associated with twice the hazard of post-discharge dementia diagnosis at 1 year following their hospitalization. Also decreased function in these patients. Patients with delirium had lower functional scores at 30 days, 90 days, and 180 days post-discharge than those who did not have a diagnosis of delirium. And they have a higher readmission rate. 4 studies showed an increase of emergency room visits or readmission to the hospital or transfer to a skilled nursing facility or even to hospice from home within 30 to 180 days after discharge from the hospital if they had a diagnosis of delirium. What can we do about it? So prevention. Unfortunately, there have been no meds that have shown any benefit in preventing delirium. Preemptive post-surgical pain management seems to be somewhat helpful if we can get on top of the pain, because we know pain can cause delirium. But there you have to be careful. So if you're using a lot of opioids, you need to watch for constipation and treat that, because that likewise can cause delirium. Non-pharmacologic measures, and this is what you're reading in all the geriatric consult notes, or you're ignoring. It's kind of long list. But that's why we put this in there. So non-pharmacologic management is pretty much all we have to prevent and try to treat delirium as well. So frequent reorientation to the date, to the place, to the time. Open the blinds so that they know what's day, what's night. Turn the lights on during the day. Sleep enhancement. So again, a lot of times on the ACE unit over at Sinai, they will actually turn the hall lights down. I don't know how the staff manage to stay awake. I'm not sure that would be helpful for me, but they turn the lights down in the hallways and they really make it, they try to make it as obvious as they can what is daytime and what is nighttime for the patients. They bundle the cares. Postpone the lab draws in the morning until 8 or 9 o'clock instead of 4 or 5 a.m. Try to not do vital signs in the middle of the night. Encourage frequent visits by family and friends. Good pain management, early mobilization, get these patients out of bed, even out of bed for eating meals. The nurses on the ACE unit frequently will walk with these patients. They also have volunteers who will walk with the patients that tend to have wandering behaviors. Remove lines as quickly as you can, restraints and tethers, Foley catheters. Attend to their sensory deficits. So get their glasses if they need hearing aids, use a pocket tucker, reduce polypharmacy. Monitor I's and O's, watching closely for constipation and treating the constipation or urinary retention, maximize nutrition. Treatment of delirium. Unfortunately, we have no meds to treat delirium. You just have to treat the underlying cause. And again, use these non-pharmacologic measures. Try to, identify what's causing it, withdraw that, and then institute the non-pharmacologic measures. We can treat agitation, so pharmacologic management of agitation, and this is used to treat severe agitation or restlessness that's causing safety concerns for the patient or their family or the staff. If you've got a patient who's aggressive and they're kicking or they're scratching, we may need to use some of the antipsychotics. So typically we use quetiapine, olanzapine, risperidone, or haloperidol. These medications can all cause prolongation of the QTC intervals, so you have to watch that and be very careful. Haloperidol also in older adults can cause drug-induced Parkinsonism, so you just have to be watching for that, signs of tremor or problems with gait. Dexmedetomidine in the ICU or Precedex is used quite a bit. This also has some analgesic effects, so this drug may be used more widely. I did find a little bit of data on this, and we'll have to keep watching. There was one small study where they were using it in an ICU versus placebo to see if they could prevent onset of delirium. So this may be a drug used in the future, perhaps. They've also used it in head-to-head trials versus propofol. To help with sedation and see if it can help with restlessness. So I think more to come in the future on that. So we'll have to really watch that. And now just a few words about terminal delirium. because that may, I think, definitely be what our patient was experiencing. Very underdiagnosed, but very common issue, occurring probably in the literature in 85 to 90% of patients in the last 24 to 48 hours of life, but can occur for several weeks prior to death. It may be reversible. So earlier on, like a week or two beforehand, maybe it's the hypoxia, maybe it's medications that were started or stopped, maybe something else, maybe pain, maybe an infection. In patients who are on chronic opioids nearing the end of life, morphine can actually be a contributor to terminal delirium. As these people are getting more dehydrated, they're developing renal insufficiency. They can develop toxicity to some of the morphine metabolites. So you may need to decrease the dose or rotate your opioids or gently hydrate the patient, all obviously in conversation with the family and what their goals are. Sometimes why this can be underdiagnosed, patients with delirium, they make grimace and we may misinterpret that as pain, and then it could actually be their delirium. Sometimes these patients then we need to use palliative sedation. And you guys obviously are more well-versed in that than I am. But it's interesting, Precedex may be something that may be helpful. There may be, obviously more data needed, but that might be something that will help. The concern with, palliative sedation then is families lose the ability to communicate with their loved one. So that always has to be the talking points there. Do we want to control the agitation and the restlessness and the apparent suffering, or do we still want to be able to communicate, and how do we balance that? So it's really kind of a difficult challenge that you guys face. So key takeaways for delirium. It's very common. We should screen for it routinely, and most ICUs do screen for it. Delirium is caused by a myriad of conditions, significant adverse long-term outcomes, particularly in the older adult population. Antipsychotic treatment is used for agitation and restlessness, for significant safety concerns for the patient, family, and staff. These are my references. And I'd like to give a shout out to Dr. Sharma and Andy Vandermolen and Dr. Groban and all the staff at Zilber. I really had a great time when I was with you guys. I learned a lot. You're doing great work there. And a shout out to the palliative team here at St. Luke's that I've been rotating with this month. You guys are amazing. I haven't met or worked with all of you, but the people I've worked with, you've been great. I really have a true appreciation for how hard your work is, emotionally exhausting, emotionally draining, and yet you guys are always smiling, and you guys do great work. I think you're appreciated by everyone, but if they don't appreciate you, they really should. You guys really work very hard. And kudos to you all.
Thank you, Kathy. That was wonderful.
Thank you.
I have a question. We know that delirium can take time to clear. It can take days, it can take weeks. There's some percentage of patients that leave the hospital still with impact that may or may not get better. How do you, as a consultant, as a geriatrician, find the balance between giving patients enough time to potentially clear and working against the pressure of the length of stay here in the hospital? Because we know that somebody's confused. Maybe they're facing a PEG tube or a big goals of care discussion. We want to keep things moving. How are you balancing that?
Yeah, that's really the trick. Sometimes if we're lucky, delirium will clear within a couple of days, if we can find what the offending problem is, and continue with all of our non-pharmacologic treatments, hopefully it will clear. Sometimes it's better for the patient to be home in their environment with less distractions, less disruptions, their familiar environment, but you have to have a safety plan in place. There has to be someone there, typically 24/7, who's able to care for them and able to make sure all their needs are met and that they're safe. And so it is difficult, but sometimes it is easiest and best for the patient to get them out of the hospital. And we have had patients who've been in with delirium where the family really has pushed to, can't we get them home? Can we get them home? Can we get them home?
Thank you.
Mm-hmm. All right, and we have a question in the chat as well. It says, can you circle back to your case and tell us what you think about the cause, prevention, and treatment?
So back to our case, the cause we never really identified. The only thing we found really was hypoxia. So after our home visit, I was on the phone. The daughter was still kind of on the fence about hospice and home hospice. And, so we talked about home oxygen. I said, well, she needs oxygen. I'm not sure why she's hypoxic. And at this point with, kind of where she was, we weren't going to be doing any huge evaluation. So she did have an x-ray completed when she got admitted to the hospital a couple days later, and it didn't show a pneumonia or anything. They didn't do a CT scan. I mean, could she have had a PE? Perhaps. She was anticoagulated, but we know she was missing some of her meds. So it could be that she had something like that was causing the hypoxia, and perhaps that was causing the delirium. But we were trying to set up home oxygen. Home hospice would easily have given her oxygen, but then we ended up setting it up through a different agency. And then she ended up in the hospital. So then she was on oxygen. I'm sorry, what else was with it? Prevention, it's really the non-pharmacologic treatments. Get back to your question here in the chat.
And then treatment is the other.
Oh, treatment. Yeah. So treatment is really the underlying cause, getting her on oxygen to help treat her hypoxia, looking for other things. There really were no other things added. We stopped the loratadine, because that was added for her scratching. And could that have been contributing? It may just have been that she was, in the terminal phase of her life. And then that was what was going on. Greatest length of time for a case of delirium. I've seen them last for weeks, sometimes weeks. Back in January, when we had this COVID surge, we had a lot of elderly patients with underlying dementia who were admitted with delirium. They were admitted with COVID, and then they developed delirium. We had one gentleman who was not vaccinated. He had vascular dementia and ended up in the ICU, and he was so agitated with his delirium and his hypoxia. He was treated with Precedex. He was on all kinds of lorazepam and Haldol and even phenobarb. And it took quite some time for him to clear, and it really became kind of a safety issue. He kept yanking at his NG, and so then we needed to have restraints, and it just was everything we couldn't do. And with COVID restrictions, we couldn't have family in visiting him. So it really took him a long time to clear, about 2.5 weeks.
Another question, there's a lot in the literature regarding various instruments to evaluate. Can you speak to those? Do you use those, or is it mostly your clinical evaluation?
Yeah, delirium is a clinical diagnosis. We typically use the 3D CAM, when we're looking at trying to diagnose delirium. There are some biomarkers that they're looking at. Nothing has, I don't believe, been proven yet. There isn't a specific lab test. CT of the head, if you're thinking, have they had a stroke, it's not going to diagnose delirium. EEG can be helpful, but it just kind of gives you that non-specific, this is consistent with encephalopathy. So it's really just it's a clinical diagnosis, and utilizing the 3D CAM. I usually start with, kind of history. Can they tell you why they're in their hospital? Can they tell you their name? A lot of times if they have dementia, they may not know what the date is. They may not know all of those things. You kind of have to parse through that. Can they tell you their name? Can they tell you their birth date? Most people with dementia can still tell you those things. And then for attention, have them count backwards from 20, have them state the days of the week backwards. If they have an inattention problem, they can't do that. They'll, start, or even 5 back to 1. Sometimes they'll do that, but they can't even do that. They'll start with, 5, and they can't go any further backwards if they have an attention problem.
Marty's saying, I think we'll wrap up for the day.
Sounds good.
Thank you so much for your presentation and for joining us. It was very insightful.
Thank you. Thank you all.